Thank you, sir, for those very kind words of introduction. It's really a great pleasure and a privilege to be here this morning to speak to this very different type of audience that we are looking at here. And I think we need to learn to get multilinguistic, and I think it's important for us to understand that there are a huge number of languages that exist in the world, and we need to at least follow the languages, if not really understand too much of what we're trying to say. I'm thankful to the Society for having given me this opportunity to be here. I feel very honored and humbled to be here this morning. I will start with a question, and I'll give you a number and you tell me what that number is. The number is 128-854-8905. Do you want me to repeat it? 128-854-8905. Any guesses on what that number is? It's not my bank account for sure. That is the population of India, or that was the population of India at 9:15 this morning. And if there is a problem with any type of this non-communicable disease like asthma that we're looking at, it's the number. The number is my problem. My problem is the number. I have too many and I have too little resources. And that's really the key here in this country as far as asthma control is concerned, because the numbers are ever so many and they're multiplying every day in leaps and bounds. It must have gone up by at least 150 from 9:15 this morning. So we'll try to look and see as to how we can combine. There have been great advances in asthma therapy, for example, the biologics and all those things. But I think the basics need to be very, very clearly defined. It's very important to draw this line between sophisticated medication and simple medication. And when we have a problem with simple medication, there's no point in jumping to the more sophisticated one. Oh my God. Okay. There I got it right. I think this is the biggest problem with asthma. Asthma is never static. Asthma is always dynamic. Every single symptom in asthma is dynamic. Whether you call it bronchospasm, whether you call it anything else for that matter, cough, expectoration, PEF, the projections are enormous. We know that they are very enormous. We thought there was an urban and a rural divide. We are not quite so sure at this point of time whether there indeed is a divide, but the factors remain that we are almost uniform and the problems are multiplying every single day. Now, I think just for a matter of interest, I think a lot of celebrities have this, and there used to be a great advertisement of the great Amitabh Bachchan using an inhaler. When I was a kid, there used to be that and used to provoke a great deal of interest. We understand today that it's a disease that occurs across the board, across socioeconomic boundaries, across languages, and across countries as well. Now, it is a chronic condition. It is reversible, airways reversibility. There's tightening of muscles and can be developed at any age. And I think this is something that we're learning to understand now. We always think of asthma as a disease of the young. At least I thought of 15 years ago. But today I need to change myself, because I get this 42-year-old guy who comes to me. I do a spirometry on him and I get a 14 to 16% reversibility. Though he may not really develop, we may not really present with those classic asthmatic features. He may have a few features of atopy, he may not have a few features of atopy. What do I call him? I don't know if I'm right in calling him an asthma. So it is important to know that the whole core of asthma is changing, except for the fact that you have this younger age group which remains the same. And then the older age groups of asthma, I think, are very, very clearly changing. Whether they are moving towards COPD or whether they are moving towards ACO with the S being taken off now, we are not quite so sure. The factors remain that there is this entity which still remains a little undefined, and I can only go back to my third year in medical school where we used to see those two Venn diagrams with asthma and COPD and a sort of intersection in between, and I think in third year we hardly knew anything about that at all. So we understand the conceptual framework is environmental exposure, susceptibility, outcomes and remission. And I think this is really what this is all about. There is a genetic predisposition, there is an inflammation, and of course there is impact of inflammation. We are trying to look at it. We look at airways obstruction, we look at bronchospasm, and we look at airway remodeling, and then we look at all those other clinical symptoms. And Dr. Narasimhan has said once the airway remodeling becomes very, very severe, becomes unresponsive, you think about very drastic things like doing bronchial thermoplasty and the rest, where you try and see whether you can get this by the hold as such. So we understand there are enormous number of mediators, and I think that's a real problem with asthma. I still remember the days that they introduced this drug, I even forget its name. Is that ketorol? Okay. That was a drug which is both an antihistamine and an anti-inflammatory drug, and they didn't know where to place that. So we, ketotifen, you're right, thank you. Ketotifen was a drug which we thought would really solve this issue because it would do both things together. It was like Kapil Dev, we could bat and bowl and field as well. And that's really what we thought. And ketotifen just fizzled out like that without question. So we understand that the effects are far too many. We've talked about childhood onset asthma, we've talked about adult onset asthma, but I think these are the three key things that we need to look at. You look at genetic predisposition, look at environmental causes. There are viral infections that kick off these things, especially in children, especially between the ages of 5 and 15. There are probably viral infections that kick this thing off, and that's really what we are looking at. This, of course, is a very complicated, sophisticated way of looking at allergic asthma. Suffice it for us to know that it's the Th2 cell that is important. There's so much work today with the Th2 cell. And of course the IgE, there's so much work on the IgE. There's so much work on the eosinophil for that matter. In fact, if you look at the biologics that are coming today, the eosinophil is a beaten cell, honestly. The eosinophil is running from pillar to post because we are chasing it all the way. Whether it's omalizumab or bernalizumab or mepolizumab, we are sort of running behind the eosinophil. And the eosinophil is probably responsible only for 3 to 5% of our severe asthmatic states. Ladies and gentlemen, are we running at 5% or are we running at 95%? I think the answer is quite obvious. The answer is quite obvious. There is no doubt that we have, I'm not saying that we should not have biologics, no. But the point I really come to stress is the fact that we need to do more about primary care and look at basic therapy rather than look at the biologics and look at all the other things that are almost impronounceable in my face. I still remember the first time this guy came to me with omalizumab. I said, oh my God, that looks like something from Antarctica. Omalizumab. And you look at all the other things that are following as such, Mepoli and Bernali and one behind the other, I think it is a tongue twister. It is a nightmare. So symptoms, of course, are cough and wheezing, and the reversibility, I think, is the key. Airflow limitation, both the FEV1 and the FVC. We know that there are various triggers, and these triggers are generally associated with childhood. And we also understand that there are basically 3 domains. The domains are the domains of spirometry, where you basically make a diagnosis, look at reversibility, then of course the challenge to produce bronchial hyperresponsiveness, and then you try and assess the inflammation. The pheno, for example, the pheno, so much has been talked about the pheno, and you know the pheno is 20 years old. It's taken 20 years for the pheno to get onto the guidelines. Can you believe that? It's taken 20 years for pheno to get onto the guideline, and even in the guideline today, it's just a sort of quiet passing mention that's more to be overlooked than looked at, really. That's the way that I would look at pheno today. Pheno is such an expensive investigation which hardly tells you much. Pheno only tells you that you are responsive to steroids. That's it. Period. And we know that already. All young asthmatics are 99.9% responsive to steroids. So we understand that pheno is no big deal. Asthmatic X-ray, of course, will be normal. There may be a little bit of hyperinflation. It's always good to associate asthma, differentiate asthma and COPD. I will never forget the day when a general practitioner was doing a talk on asthma. He got up and told me, why do I need to differentiate asthma and COPD? Anyway, I'm going to give him the ICS LABA. For asthma, I give him ICS LABA. For COPD, I give him ICS LABA. Why do I need to differentiate? So I had to answer him and tell him that your endpoints when you treat asthma and COPD are different. Asthma is reversible. You're going to reverse the whole process with asthma, whereas in COPD you're just hanging on. COPD is like catching a tiger by the tail. You hang on for dear life and then try and see what best you can do on that. And I think that's the key here. The key for us to understand is that there is a difference between COPD and asthma, but the difference is slowly evolving over a period of time, especially now with studies like the flame and the wisdom and the crystal and all these things which are really telling us that the LABA LAMA in COPD and the ICS LABA in asthma. Spirometry, of course, we understand today spirometry is important. There is no question that there is no diagnosis of asthma without spirometry. We understand there are many types of spirometry, and we all know this. I don't really think this is rocket science. The sort of concave downsloping loop that we get in patients with asthma. But you look at the area survey, and I think it's a very interesting survey, and look at the differences between treatment guideline recommendations and survey guidelines. And I think just one thing I want you to understand. Gina says you must have near normal lung function, whereas 72% of patients had never even seen a lung function, leave alone had one. And I think that's the pathetic state that we are looking at today. We have patients who are not really diagnosed or not really diagnosed asthma, and we go running from pillar to post when we're not quite so sure. And this is, of course, Gina assessment of asthma control, and I think risk factors for exacerbation. The best risk factor for exacerbation is the previous exacerbation. The highest risk factor for an exacerbation is a previous admission and a previous ventilation for asthma. But I think we need to understand today that the asthma medication that we have today are so good and work so very well that we've almost forgotten when I ventilated my last person with pure asthma. Now, the treatment is so good, there are so much of nebulizer, there is such a great deal of awareness, there is so much of information circulating around that these patients are generally well controlled. You look at management, what have we got in management? In 75 we had SABA and the theophylline, and that's what we started off with. We retained the theophylline in countries like ours. Theophylline will never die a death in this country because the drug is a household brand name. It's like your cooking oil that you use every single day without question. Then of course we had the LABA and the LAMA and the Montelukast and the combination of the ICS LABA. And when we had the combination of the ICS LABA in the 2000s, we thought that we had asthma by the scruff and the whole business of asthma treatment was over. Now only to understand that we had this therapy which was the smart for both maintenance and relief. And then we had the once daily LABA LAMA that's coming up. We have tiotropium, then we have omalizumab, today we have bernalizumab, and we have mepolizumab as well, and then the anti-IL-5 medications. And tiotropium, of course, recently approved for asthma. And this is the segment that's being used for what we today describe as a severe asthmatic condition. So this is really the history of asthma treatment, starting from plain theophylline and the short-acting beta agonist down to tiotropium today. So today we target not only control but also look at future risks, and that's what Gina asks us to do. So look at review response, look at review response, look at assessment, and then of course you try and adjust your treatment. And then of course, as I said, this is the acute asthmatic sequence that we are. But I think the one thing we need to understand today, you don't need to be in step 4 and step 5 to get a severe asthma attack. You can get a severe asthma attack here, you can get a severe asthma attack here, which is the reason why I think there's a huge deal of opposition to this step 1 in asthma where you use only the short-acting beta agonist. The Philippines, for example, in their guidelines have totally eliminated step 1. Not today, not yesterday, 5 years ago. 2010, they showed me a guideline which had no step 1 at all. You start with the ICS LABA and proceed from there. Once you diagnose asthma, you know that there is a chronic inflammation. You start with ICS LABA and stick with it, and all your problems related to the short-acting beta agonist begins with the fact that you prescribe a short-acting beta agonist in isolation in the first place. And what do you tell him next? You tell him, no, you shouldn't be using that. You give him a drug and you tell him you shouldn't be using that, and I think that's, in my book, close to ridiculous. So I think we need to stop providing this SABA in isolation and probably use the ICS LABA as well, as we look into it a little later on. So there is current control, there is normal lifestyle, there is future risk, there are inhaled medications, there are oral medications. We'll see why inhaled bronchodilators, of course. We have beta agonists, we have anticholinergic, short-acting, long-acting, then salbutamol, levosalbutamol, salmeterol, formoterol, ipratropium, tiotropium. You go into an extension of this, of course, you will get indacaterol, you will get vilanterol, then of course you will get glycopyrronium, you will get aclidinium. Now these are once daily acting drugs, which probably, I think, will be ruling us over the next period of time. As it is in asthma today, a combination of vilanterol and fluticasone is already approved in a device called the Ellipta, which is available for once daily treatment of asthma. And I think we're looking down this sort of ultra long acting beta agonist pathway when we look at these drugs. So inhaled corticosteroids, beclomethasone, fluticasone and budesonide. The chromones are no longer very active. Then of course you have the leukotriene receptors. Inhaled steroids reduce inflammation and should not be prescribed alone in patients with asthma. They have warnings as such, but then the fact does remain that inhaled steroids always works better in patients with a combination as such. Steroids, of course, are only for emergency. You use them in emergency situations, whether it's prednisolone, methylprednisolone or betamethasone. I think a lot has been talked about devices without question. Devices are personal, individual choices that are based on ease of use, efficacy, cost, many overriding factors, availability, not availability. And I don't really think inhalers by themselves are a different topic altogether, but the fact does remain that we need to familiarize ourselves with every single inhaler available, weigh the pros and cons, then try and see what is best for our patients as we look at them. So of course there are spacers and holding chambers, and please use an MDI with a spacer only. And I think that's the bottom rule that we have. If you use an MDI, please use a spacer, because without a spacer an MDI becomes almost useless, and it's important to use some holding chamber which will improve your MDI. There are, of course, the peak flow meters are a dime a dozen today. Many things are available, and please understand that it's in asthma and asthma only that you can use the peak flow meter. The peak flow meter is not a very good instrument in patients with COPD, whereas in asthma it's good. It's a good prognosticator of you getting worse or getting better as we go on. So why do you need inhalation therapy? You have rapid onset of action, less amount of drug, better tolerated treatment choices. You sort of contrast that with slow onset, large doses, greater side effects, and not useful in acute symptoms. And this is really what it is today, where we are today. Now, if you look at 1900, we had adrenaline, isoprenoline, salbutamol, terbutaline, salmeterol, and formoterol, cortisol, BDP, and budesonide, and formoterol. Then these two have come together in this fixed dose ICS LABA combination. And ladies and gentlemen, it's taken 100 years for us to do this. 100 years for us to know that an organ called, an organ which is about 5 grams in size and placed in a very obscure part of the abdomen can produce these two products to come together and give us what is called combination inhalation therapy. And I think that's really what we are looking at today. Combination inhalation therapy has come to stay. Whether you're using a LABA-LAMA or today or tomorrow you're using an ultra LABA-LAMA, it doesn't make any difference at all. The fact does remain that the ICS LABA is really what is important. Now this was the one that really established the LABA combination. The facet, if you want to do the facet in one line, it's this. It says you add a long-acting beta agonist to an ICS is better than doubling the dose of the ICS. That's it. You don't need to go into the details of the facet. The facet will tell you that you add the LABA to the ICS is better than doubling the dose of the ICS. The facet study very clearly gave us that. So the conventional way of looking at dosing in asthma today would be to start down and go high, as the gene asks us to do. You start and you step and you go up. go up and up and up. But in countries like India, for example, where patients want to get faster and want to get better faster, you'll always find that it'd be better to start up and come down. I would start with 2 puffs 3 times a day of the ICS LABA, then slowly work my way down where I'll get much better control, much faster control, though it may not be in concurrence with the GINA guidelines. The fact does remain that it's extremely practicable to do such things. The ICS, of course, is a very famous paper from Sami Susi et al., which occurred in the New England Journal, I think way back in 2000. Now this really talked about the ICS and said that the more ICS you use, the less asthma death, the less ICS you use, the more asthma death. It's a very clean statement of fact, and I don't really think there's any argument about it. So these are the beta agonists that we're looking at. We're looking at a fast onset, short duration, slow onset, short duration, slow onset, long duration. Then of course we have fast onset and long duration. And the only drug that satisfies that criteria is of course salmeterol. Now why does it satisfy that criteria? It means that salmeterol is intermediate, long duration, and it's got a fast onset. So salmeterol is superior formoterol is superior to salmeterol because of 2 reasons. Number 1, it's got a longer duration of action. Number 2 is that it's got a dose-dependent action in the sense that you increase the formoterol, you get better bronchodilation. You decrease the formoterol, you get worse bronchodilation. But in salmeterol, of course, if you increase, you probably will get more side effects without question. And that's what I meant when I said that formoterol has a dose-dependent action. Where you increase the formoterol, you get much better action. Almost like a salbutamol, for example. The formoterol will work like a salbutamol in such situations. So of course, similar 12 hours of action, but then as I said, there is a quick phase and a continuation phase, and also the fact that is dose response, SPOI approach is really what you're looking at today. And because formoterol is almost equal to salbutamol, you can use the SMART approach where you think that you use the same ICS LABA combination. Very early in this stage, when he picks up the exacerbation, you'll be sort of avoiding steroids and moving to the other phase that we're really looking at. So this is SMART therapy. Levels of asthma control, of course, have changed. We've changed from the persistent and the intermediate to controlled, partially controlled, and uncontrolled. And I think there's a much better way of looking at things. You look at the clinical phenotypes of asthma and look at this. And I think this is the real mess that we find ourselves in. 15 days ago, I did a talk on asthma phenotypes to GPs. And I sort of got down from the lectern. I was very happy. I thought I'd done a great job. Collars up, I came down. And then this guy who was a friend of mine, general practitioner, came up to me and said, "Prasanna, for the first time in your life, you've accepted that you don't know." I said, "My God, I did so much for the lecture and you give me a compliment like that." He said, "Phenotypes means you don't know." And then I went back and thought about this, and I thought how true what this guy says. The phenotypes, you sort of branded a phenotype because we think we don't know. Anything that you don't know, you brand a phenotype. 42-year-old asthmatic comes to you with 14% reversibility. You don't know what it is. You call him an adult onset phenotype. Done with the diagnosis. We've got all the terminologies in place. And I had this very peculiar experience about 3 months ago. A father had come once to me with asthma. The next time he brought his son. His son came and asked me, "Doctor, how is his phenotype disease?" I said, "Oh my God, phenotype is not a disease." The fact does remain that we use these terminologies very loosely, and I think we need to be more careful about it. The phenotype we need to understand and explain is a sort of type of progression that the disease has, and I think it's important. Now just to look at the phenotypes, you have early allergic onset, late eosinophilic onset, exercise-induced, obesity-induced, neutrophilic, and then of course we have severe asthma, which we think is a very different phenotype today. As Dr. Narasimhan very rightly said, severe asthma is probably a different disease from asthma itself. There's difficult to treat asthma, therapy-resistant asthma, and problematic severe asthma. And we also find the good news is that the condition is rare, as he's very rightly said, it's less than 5%. The bad news is that it impairs the quality of life, and clearly very, very severe medications like thermoplasty are probably indicated for such patients. Now, this of course is omalizumab, and we find that with total IgE, there's a definite control without question. So you approach it with uncontrolled asthma, frequent exacerbations. You look at the specific phenotypes and step up with high dose of ICS-LABA and the LTRA and the OCS. This is what I told you when I told you about the tongue twisters of the biologics in asthma that we're really looking at. Look at the number here, and I think if you can read out all these things in one breath, without pausing, I think you need to be a Usain Bolt to do that. So it's so difficult to sort of pronounce all these things and get away in one line as such. But we do understand that these are things that could become very specific in the future. It's not that I have anything against the science. The factors remain. Are we prepared for these drugs today? I'm not sure. I'm not sure that we are prepared for these drugs today. When a basic care is gone for a 6, I really don't know whether we are prepared for this today at all or not. So you look at asthma, early onset, late onset, and I think this is a nice way of looking at asthma. Early onset asthma is your classical asthma, whereas your late onset asthma is probably your non-classical asthma. Then you get all the inflammatory phenotypes that are sitting out of that, and you look at the number of types of asthma that you have. Th2, atopy, exercise-induced asthma, allergic asthma, AERD, late eosinophilic asthma. This is Th2. Non-Th2, you have early, very, very late onset asthma, obesity onset asthma, smoking associated neutrophilic asthma, smooth cell mediated posigranulocytic asthma. What is this? Are we writing a new textbook on the asthma? I think we are. How many types of asthma do we have? I think we've forgotten. At least I have forgotten. So we need to understand that we need to get some clarity into all this confusion, have our own way of dictating the way that we look at these things. So we look at the treatment of asthma and COPD, and I think this is one takeaway slide that we can take away. Asthma is ICS, is dominated by the ICS, and COPD is dominated by the LABA-LAMA. And I think if there's one thing that we imply, it is this. The short-acting beta agonist is sitting out here, and there is the LABA-LAMA that you can use if you need, and there is the ICS that you can use if you need them. And I think this really describes the core to us and what is important for us. And finally, do we hear patients or listen to them, maintain a positive attitude? I think it's important. What is the difference between hearing and listening? I think we can go and look up the dictionary for that. I hear because I have to hear somebody singing in the next room. If I don't hear, I'm deaf. So I hear. I'm listening when I want to find out what you're trying to tell me. That's what it is. Do we listen to patients? Or we hear them? I think we do neither. We are looking at this guy sitting across. I got up at 2 o'clock in the morning. I had a cup of hot water. I took 2 puffs of salbutamol. I opened the door. I couldn't breathe. And what am I doing? I'm signing some papers. The nurse is walking in with the sheet. The phone is ringing. And I'm talking. We are multitasking at every single level where this patient goes on with this sob story. And I think this needs to stop. Unless this stops, there's no question of trying to get around to patients. Absence of symptoms is not absence of disease. And I think that's very important when you stress that continuity of treatment is important. And I think it's very, very important to take that as well. So we will say that, we'll just end with these things. In taking up the study of disease, you leave the exact and the certain for the inexact and enter a realm in which to a great extent certainties are replaced by possibilities. And I will just close with this gentleman. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. Anybody want to take a guess as to who said this? We started with a question and we leave with a question. This is a Frenchman, Marcel Proust. Thank you for the patient listening.
Thank you very much, Dr. Thomas, for this very interesting talk. I'm sure you got many questions from the audience. Well, about the...
Thank you very much, Dr. Thomas. It was a very, very nice, interesting, and have given a practical way of looking at things, because so difficult diseases, and and it's a disease which kills every day so many people, and yet we have the treatment we have, and we're not well diagnosed it. We're not talking and try to. We doctors don't listen, don't hear, and at the same time we don't. How can you explain? I just said something like this. When you go for exam, when you are a student, we go to exam, and you have to read your courses before going for examination. You have to do it 4 times. I was not very good, so 5 times. And to reach a question, to have 50 on 100. How can you have a patient in front of you, in 15 minutes you have to explain asthma and give him them and think that he will be doing it correctly for life? So this is a question, and it's very interesting what you have been saying. We have to go through, doctors must listen, and this is very, very important. We are not used to that. We are used to go rapidly, thinking of science, high science, and we neglect this fundamental science, which means we need communication, and communication may lead to very far than we at the high science. I agree with you. Thank you very much for that.
So the Department of Psychiatry in Government General Hospital did a study on physicians in general, and they came to the conclusion that the diagnosis of the disease was made within the first 2 minutes of this patient walking in and sitting in front of you. The diagnosis was made in 2 minutes, and after that there was 80% confirmation that it was there and probably 20% that it was not there. I think we are in a hell of a hurry to make up our mind, simply because the next guy is sitting outside and he needs to walk in, and our time is limited, and I think we are limited by the fact, and that's the reason why I started with the population of India. And I think in a country like mine, I think it's a tremendous problem without question. My general practitioner will see about 150 to 250 patients, and where do you think he has the time? He just doesn't have the time at all. He may not have time for lunch for all I know. So I think that's really what we're looking at. Yes.
Yes, sir.
Yes.
Thank you very much for a very nice talk you delivered just now. And as a general practitioner myself, it is true what you're saying, taking time to listen to your patient. And especially, do not add years to life, but adding life
to years.
Yes, this is what the basic of your talk is about. So indeed, it takes only 2 minutes and 30 seconds. If you shut your mouth as a doctor and you do not talk, in 2 minutes 30, basically, the patient would have told you everything. That's the first thing. The second thing, I suppose I've not heard about the usual techniques of breathing, education in breathing, because we do not breathe as babies do. We breathe in a different way, in a situation which is complicated. And the third thing is about the number of people. There are some studies, I forgot what are the reference of these studies, but there are studies saying that only 35% of patients, or chronic patients, would take their medication. Is that true?
I think so, because the level of understanding is so poor. You take a disease like asthma, for example, you find the compliance levels are so very poor at all, because patients equate symptoms with disease, and I think that is the problem. The problem with asthma is because patients equate symptoms with disease. When I'm symptomatic, I have disease. If I'm not symptomatic, I don't have disease. And that's the reason why I often have a caption where I have a sticker and I stick it at the bottom of every prescription, which says absence of symptoms is absence of disease. I don't know how many people read it, but then it's there. So we need to tell them that absence of symptoms is not absence of disease. I'll just give you a small example. I had this very educated girl who was working in one of the big computer companies. She was admitted in the ICU. I saw her for the first time, asthmatic. They gave her all the wonderful medications that we have and discharged her in one day, and she went out. And I gave her an ICS LABA inhaler and told her to use it regularly till she came back to me. I see her 6 months later in the same bed with the same exacerbation and with all these medications around her, and I asked her, look here ma, I did tell you before 6 months that you need to use this inhaler regularly. You know what she told me? Path-breaking, I'll never forget it all my life. She said, Doc, you told me what will happen if I took the inhaler. You didn't tell me what will happen if I didn't take the inhaler. It struck me really at that point of time that we need to give them the flip side of things. What happens when you take medication? What happens when you don't take medication? We hardly talk about that at all because we are worried that this patient may think of as a very depressive doctor and may try to find a slightly better doctor next time. So I think this is important that you say you take your medication, you're like this. You don't take your medication, you're like this. And you will go here from here to here. I think it's very, very important that we tell patients the flip side of things.
Another question? Perhaps I will have one question about,
yes, sir.
You've not talking about the ACOS syndrome.
Okay.
What about, what's your opinion on that?
Sir, the ACO is, they've taken the S off for whatever reason, I don't know. But the fact does remain that I still remember this graph I told you about from third year in medical school with two circles of asthma and COPD and a sort of thing that is stuck in the middle. I'm sure all of us know that. We've always known that it existed. Just giving it a brand name, I don't really know what it's going to do. I often tell my PGs at least that the best way you can go to sleep is to read the echo in the GINA. You just read through it and before you finish 2 paragraphs you'll be off. You don't need a sedative at all. It's so terrible and so terribly boring and hardly informative that you really don't think that's the right way of doing things. So I think it's just giving a terminology to something that's always existed. Number one. 2, it continues to be as confusing as it has been all these years. I never make it not a point to point to this 42-year-old asthmatic I told you about with 14% reversibility. What is it you call him? I don't know. I really don't know. So I think the ACOS is still very, very uncharted territory. And though they may today drop the S and tomorrow they may add something else, no, that's all besides the point. For us clinicians, I think the terminology is not important. What we do to our patients is more important than the rubber stamp that we sort of really stamp them with. And that's really what this is all about.
Thank you very much, Dr. Thomas.